Wondering why your patient is in shock? The EGLS algorithm may hold the answer. Let's now look at the examination sequence needed to answer these 5 clinical questions. Starting with question number 1, is there a pneumothorax? To answer this question, we will go interrogate the anterior surface of the lung, thus going on the anterior thorax. On each side of the chest, we will go look at 4 spots. 1 more medial, 1 more lateral. First near the apex, and then around the 5th or 6th intercostal space, repeating these steps on the other side.
Now, obviously, the next step is optional, but you may also want to consider removing the belly button lint of your patient.
Whether you choose to do this additional step or not, we will next orient the marker of the probe towards the patient's head, going to look for lung sliding, lung pulse, or the presence of B-lines on both sides of the chest.
Once pneumothorax has been ruled out, the next step will be to rule out tamponade, and this will be achieved through the subcostal window, which is a sensitive view to detect pericardial effusion. Once the pericardium is assessed, we're going to look for signs of hypovolemic or distributive shock. And we also have in that window the IVC that we can look for, and this will help us further refine our interpretation. The subcostal 4-chamber view is performed by putting the marker towards the left of the patient and putting the probe in the epigastric region. From this position, if we do a 90-degree counterclockwise rotation, we will be able to assess the IVC in its longitudinal plane of cut. We can also assess the IVC directly by putting the marker towards the head of the patient and slide the probe laterally until we find the IVC.
If the patient isn't clearly hypovolemic or distributive, we'll have to assess heart function. We'll start by doing the parasternal long axis view by placing the probe around the 3rd intercostal space near the sternum, orienting the probe marker towards the patient's right shoulder. By putting the probe in the thorax, if we don't immediately see the heart or can't find it, we will do what's called chest surfing. And once we get something that looks like a parasternal long axis view, we'll then optimize the view by doing rotations to put the probe in line with the long axis of the heart. Then, by tilting laterally, we'll find the plane of cut that goes through the middle of the left ventricular cavity. Going from the long axis view, we'll orient the probe towards the patient's left shoulder, thus generating the parasternal short axis view. Once we found the short axis view, and we'll do this by turning the probe clockwise, the main challenge here being that we have to stay on the same point of contact. Then we'll find the level we're looking for, the mid-ventricular level, the level at which we see the papillary muscles, by doing a fanning motion from the apex to the base of the heart. The last focused echo view we'll be doing is the apical 4-chamber view. To obtain this view, we'll orient the probe marker towards the patient's left, towards 3 o'clock if we were to compare him to a clock. The first step is actually to find the apex, to put the probe directly on top of the apex. On the screen, the apex will become on the middle of the screen. Once that's done, we'll tilt the probe laterally to verticalize the septum, then fan anteroposteriorly to obtain the 4-chamber view.
So to resume, we slide, we tilt, and we fan. So this was the EGLS sequence, and now we have playing the complete sequence of examination. And basically it's really simple. The first 2 questions allow us to rapidly rule out things that can be rapidly reversed with a needle. And the last 3 questions, well, it's basically to categorize your shock. And with the right training, doing this sequence will take you only a couple of minutes for most of the patients. Oh, and also you have to remember that you need to put some gel if you want to actually generate some images. So we are really looking forward to see you at the course. And remember to follow us on Twitter.